Hello students, so this is just a video session for obstetrics and gynecologist, so OG. So we'll be seeing some cases. This will not be a regular case based session or regular discussion. This is just for how to know the clues that will be given in your FMG examination for coming to a diagnosis and what to do at the next point. So this is just for not for knowledge purpose, this is just for your exam purpose. So since it's the last minute of your exam, so I'll just like to keep it short. So to start with, the first case that we need to see in OG that often occurs is per vaginal bleed. So PV bleed, this is a very important topic. So in this, I'd like to take three things in consideration. Number one is placenta previa. Number two is placental abruption. Number three is pelvic inflammatory disease. So these three are very important, and these three, you should know these 3 points when you are sitting for your examination. So to start with, placenta previa means this bleed is painless. In abruptio, this bleed is painful. In pelvic inflammatory disease, there is a history of sexually transmitted disease. So chlamydia, gonorrhea, STD. So these three are the first important thing that you need to know. Number two, in PID, there is going to be a discharge, vaginal discharge, whereas in placenta abruption or placenta previa, there is no discharge. Okay, we'll talk about them separately. So to start with placenta previa, so whenever you get a case with per vaginal bleed, which is painless bleed, you should think of placenta previa, and this has no cause. So it will not be given a history of cause in your question. So it is painless, causeless bleed. First thing you have to look for this patient in your MCQs, your BP. If the BP is low, regardless, placenta previa has their own grades. Regardless of their grades, when the BP is low, you have to stabilize the patient with IV fluid. Stabilize the patient. If the BP is normal, then look for signs of instability. So look for tachycardia. So how is the heart rate? Is it normal heart rate or is it tachycardia? So this differentiation should be thought of. So if it's a tachycardia, it can be a minor degree, it can be a major degree. If it's normal heart rate, again the placenta previa can be a minor degree or it can be a major degree. Minor or major degree. So in all cases you will go for LSCS except placenta previa with a normal BP, with a normal heart rate. In minor degree you will go for normal delivery, vaginal delivery, normal delivery. Anything else is going to be LSCS. This is as simple as that. So this is how you have to approach for the case in placenta previa. I hope this helps. So we'll talk about placenta abruption. So placental abruption means, yes, there's going to be bleeding, yes, there's going to be pain, yes, there's going to be a cause is going to be there. So probably you'll be given a history of trauma or fall, after which patient is profusely bleeding with pain. When you touch the uterus will be, number one, it's tense, number two, it will be tender, tense and tender. So for your MCQ purpose, you need to know about the fetus. So what you are going to do in this patient is based on how is the fetus. Is the fetus is in distress or not? If the fetus is in distress, you need not worry about anything. Directly go for LSCS, save the fetus. That's the primary step you should do. If the fetus is not in distress, you could first try labor induction. If that fails, you could go for LSCS. So this is the approach that you need to know for placental abruption. So for a case in placental abruption, this is the step. I repeat, placenta previa means if you want to do normal delivery in that patient, how the case should be: case with per vaginal bleed, no pain, no cause, normal BP, normal heart rate, and minimum minor degree. Anything else, it's going to be LSCS. The mode of delivery, you will be talking about the mode of delivery in your MCQ only if the BP is normal. When the patient is having low BP, you have to stabilize the patient. That is the primary goal, because first the patient should be alive. Okay, so stabilizing the mother is the major goal when there is hypotension. So that stabilization is IV fluids. I hope it's clear now. Placental abruption means painful, causeful per vaginal bleed, probably history of fall or trauma. The uterus will be tense and tender. If the fetus is in distress, you will do LSCS. If the fetus is not in distress, you will do first labor induction. If that fails, you will do LSCS. I hope it's clear now. Going to pelvic inflammatory disease. So pelvic inflammatory disease means either chlamydia or gonorrhea, one of these two, STI. So whatever the history of chlamydia or gonorrhea, it should be present in your question. So talking about chlamydia or gonorrhea, okay, I'll make PID as a separate topic here. Pelvic inflammatory disease. So it is inflammation. Inflammation means fever. Inflammation means pain. Inflammation means tender in abdomen. In pelvic area, if there is inflammation, these three things should be there. Inflammation, so some infection leading to inflammation, it is chlamydia, gonorrhea, let it be. So some infection leading to inflammation, so there has to be a abnormal vaginal odor, AVO, abnormal vaginal odor, smell. So that is very important. Now, how you will be tricked in this question? You would be told, you'll be given a clue that this patient is having right upper quadrant tenderness. Right upper quadrant tenderness. This means perihepatic spaces involved around the liver. Perihepatic spaces involved. If you are given right lower quadrant tenderness, read the question carefully. Is the pain migratory? Is the tenderness or pain migratory? Did it start from umbilicus and go? So migratory pain from umbilicus to right lower quadrant is going to be appendicitis. It is not PID, appendicitis. So when you have to know about the tenderness generally in PID, it is bilateral abdominal tenderness. Only when perihepatic area is involved, there is going to be right upper quadrant tenderness. Otherwise, it's going to be bilateral upper abdominal tenderness. So bilateral abdominal tenderness more than right upper quadrant tenderness. So this you should know about pelvic inflammatory disease. Another same type of presentation, another DD that you need to know. First DD we have seen already, appendicitis. The next DD you need to know is ectopic pregnancy. So in ectopic pregnancy, they will tell you beta HCG is high. There is positive pregnancy test. Okay, so that's it about pelvic inflammatory disease. Then coming to, so in short, pelvic inflammatory disease, you will be confused with appendicitis or ectopic pregnancy. Appendicitis means migratory pain from umbilicus to right lower quadrant. Ectopic pregnancy means positive pregnancy. There is beta HCG would be high. Okay, so these two DDs you must know. Next, coming to the next case, positive pregnancy test. That is high beta HCG. is given in your exam. The uterus is enlarged, uterus size is big, amenorrhea is there, that is missed menses, amenorrhea, missed menses is there. What it could be? So these three, beta HCG plus uterus is enlarged plus amenorrhea. You will have 3 DDs. Is it a normal pregnancy? Is it ectopic pregnancy? Is it a H-mole? So this is a point where you should know how to differentiate between them. Number 1 is your vaginal spotting. In normal pregnancy there will be no vaginal spotting. It will be there in ectopic pregnancy and H-mole. So if they initially told about vaginal spotting, if there is no vaginal spotting, still look carefully for something, that is ultrasound report. If they have not talked about vaginal spotting, look into ultrasound report more carefully for normal pregnancy. Why? Because there are 3 possibilities. In 4th week you will see a gestational sac. In 6th week you will be given with heartbeat. In 12th week you will be told about crown rump length, CRL. So this is important for sorting out the MCQs in normal pregnancy. If it's ectopic pregnancy, first of all uterus will be empty. So uterus will be empty. Because the fetus is not even reaching the uterus. That's the main problem, right, in ectopic pregnancy. So the uterus will be empty. And cul-de-sac will be filled with fluid. Cul-de-sac fluid will be there. So these 2 things you should know in ectopic pregnancy ultrasound. If they have to tell you it's H-mole, they have to give you a ultrasound finding, that is honeycomb appearance in ultrasound. So these points will differentiate when you get a case with positive pregnancy, that is beta HCG is high with uterus size is big and amenorrhea, missed menses, in other words, that is amenorrhea. Since in pregnancy continuously the menses will be missed, so you are not going to get any spotting. So that is the major clue. But many times you will not be told about the spotting in your MCQ. So it will be directly asked with the ultrasound finding. So you should know first the ultrasound finding. If they tell about the spotting, still it is common in ectopic pregnancy and H-mole. So you would anyways go for ultrasound. So memorize the ultrasound findings. That is very, very important. I again repeat, in pregnancy, in 4th week gestational sac will be seen. In 6th week heartbeat will be felt. In 12th week crown rump length will be checked. In ectopic pregnancy, empty uterus, cul-de-sac fluid. In H-mole, honeycomb appearance in ultrasound. Okay. Then the next important topic in OG is you be given a pregnant patient, for example, just few weeks before delivery, maybe 32 weeks, let's say, or 34 weeks, or 36 weeks, regardless of any week in this presentation, if the patient is having a seizure. So this is a very, very important point. If the patient is having seizure, and once the viability age of the pregnancy has been crossed, if the mother is having seizure, first your management should not be about saving the baby, it should be about saving the mother. So first manage the seizure with ABC, airway, breathing, circulation. So first is ABC management for seizures. Then you have to look 2 things. Is the patient in labor or not? In active labor or not? If the patient is in active labor, you can give oxytocin. If the patient is not in active labor, you have 2 options. Either you will go for LSCS or you will go for forceps or vacuum. So look at the cervix. If the cervix is open, you can go for forceps or vacuum. A vacuum can be used only when the baby reaches +2 to +3 station. Okay, so it's almost fully dilated. If the cervix is open, it's almost fully dilated only, you can go for these options. This is in another words that will be given in your MCQs: cut shorting the labor, cut short of second stage of labor. That's another word trying to tell you that you are going to use forceps or vacuum. That is based on the cervical dilatation. But if the cervix is closed, or the cervix is open but not in much size, so cervix is closed means you are going to go for LSCS. The reason is, in a closed cervix, that to a patient post seizure, the baby is supposed to get hypoxia. So if the cervix is closed and you are waiting for the patient to be in labor, that's not going to happen, because first of all the patient is not in labor. So if you keep on waiting, by the time the delivery month comes, the baby would be dead already. So you have to cut short it by LSCS directly. This word is called as termination of pregnancy. Termination. In your MCQ, you will be getting a word that is termination of pregnancy with LSCS. Okay, so that's it about seizure in pregnancy. A very important MCQ that you need to know in pharmacological aspect in seizure in pregnancy is, if the patient is already on some drug, for example valproate, previously before pregnancy, in pregnancy if she is getting seizure, you should be treating her with the same drug only. So that is for MCQ purpose. Do not change the drug. Okay, if the patient is already a known case of seizure and in pregnancy again she is getting seizure, the drug of choice will be the similar drug that she have been taking for a long time. Okay, so the next topic that we need to know is abortion. Abortion is often confusing and often mistake making MCQ. I'd like to make it very, very simple. You have to know, is it a septic abortion or not? First point. So look for the septic abortion features like fever, hypotension, low BP, tachycardia, high heart rate. If they are giving WBC count, that is going to be elevated. Okay, or in SIRS criteria, it is going to be low, less than 4000. So your management is first manage the sepsis. So you are going to give IV fluids plus antibiotics. If you have been challenged about the decision of which one to start first, look for the BP. If the BP is low, first is IV fluid till the BP is normalized. If the BP is normal, but they are talking about the WBC count and fever, the BP is normal means you can go for antibiotics initially. Okay, but if it's not septic abortion, you will have all the other formats of abortion, either incomplete or complete or inevitable or threatened. Okay, and then there's something at loss, that is missed abortion. So in any format, only one thing you should know, that is cervix. Is it open or closed? So in incomplete, the cervix will be open, because from the uterus partially some amount of the fetal product of conception has come out and rest is remaining inside the uterus. So the cervix will be open. So only some part is remaining in the uterus, so the uterus size will be small. So if, for example, this is the uterus size, this much is the fetus content, and this partially like 50% of it has already come out, the uterus size will become like this with some product inside. So that you need to know. But that is not the case in complete abortion. Complete abortion, cervix will be closed. Why? Because there is no role for cervix to be open. If this is the product of conception, everything has come out, so the cervix will be closed totally. So again, the size of the uterus is going to be small. The size of the uterus is going to be small in both incomplete and complete abortion. But cervix is open in incomplete, cervix is closed in complete. So this point you need to know, that's very important. Coming to inevitable versus threatened abortion, both of them are very, very, very important and very, very, very common in first trimester of pregnancy, early pregnancy, both will occur. So if you would like to know the major difference in this is, yes, in the first difference is the cervix. In inevitable, the cervix is going to be open, and in threatened, the cervix is going to be closed. But the major difference that you need to know is, in inevitable, the fetus is going to be dead, and in threatened, the fetus is going to be alive. So in any case, the fetus is still inside the uterus, so the uterus size will be normal with fetus. The uterus size will be normal with fetus as per the pregnancy. Normal means as the age of gestation. The size of the uterus is similar to the age of gestation or period of gestation, whatever you call it. The last is the missed abortion. Missed abortion means the mother doesn't even know that abortion has occurred. So dead fetus and cervix is closed. This patient is highly risky, because the dead fetus is there for longer time means it will go into something called DIC, disseminated intravascular coagulation, and that would be a drastic life-threatening situation. So this patient definitely needs immediate termination of that pregnancy. Termination of pregnancy. Now, coming back here, if it's incomplete, regarding the management, if it's incomplete means still some product is there inside, so you have to take it out, so you are going to do DNC. If it's complete means everything has come out, so no treatment is needed. If it's inevitable, dead fetus is there, you have to take it out, so DNC. If it's threatened, alive fetus is there, you don't have to do DNC, because the fetus is alive, you have to support the pregnancy, so you are going to give progesterone. That is the main point I would like to say, progesterone. Threatened abortion, progesterone should be given. In anywhere else, you would go for stopping the pregnancy. Either you would try to terminate the pregnancy with DNC, or in like in complete abortion, you are not going to do anything. But that's not the case in threatened abortion, because the baby is alive inside. So you will go for progesterone. So this much if you know for abortion, all the questions that will be asked from abortion should be fine in your FMG. Then the last topic that you need to know is vaginal discharge. I'll make it very, very simple. If you get a case with vaginal discharge, you might have read a lot about it, but for FMG, you are expected to know probably 3 things. One is it fishy? Is it green? Or is it curdy white? Curdy white. In any case, your treatment is not going to change. So your drug of choice is going to be metronidazole in any of the case. So that's not the problem. You will be asked for knowing which is the condition in which you are going to get it. Fishy means bacterial vaginosis. Green means Trichomonas vaginalis. Curdy white means candidiasis. So only these 3 things. So this is a bacteria, this is a Trichomonas vaginalis is a parasite, and candidiasis. Okay. Fungi. Candidiasis. So I hope all the topics in gynecology has been covered here. Major topics that you need to know for your, there can be still further topics, I would discuss about them later, but before going to examination, these topics must be covered very, very keenly. So in next video session, I will try to expand it with some more topics if possible. Thank you so much. Good luck.